So we have another volunteer from here, from HHIF, that is Tanushree Kocham. Yeah.
Hi, good
Tanushree,
evening.
Yes, hello, I'm Tanushree. I've just recently joined the team as a management and operations intern. Looking forward
Okay.
to the chat today.
So what is
yeah,
this all about? Give me some introduction. What is this about?
yeah, sir. So this session would be like an interview session. So we have Dil Ke Daud sessions for Heart Health India Foundation. So we would pick up topics, that are mostly asked by people, heart attack survivors, people who are concerned about their heart health. So many things like that. So we try to build questions or topics around it, and we contact people, healthcare professionals who can, give a talk on it, who can give an advice on it, and we get to connect with them, and we have this kind of podcast, video kind of thing, and then we uh, record it and we publish it on YouTube on our social media handles, so that everyone who's interested in it can access it. We are just creating awareness. We are spreading the information.
Perfect. Go ahead.
Okay. Uh, let me begin. So I'll introduce Heart Health India Foundation first.
Okay.
So I think you are also aware about Heart Health India Foundation.
Yeah.
So the founder, Khandelwal, he had contacted you, and you are one of the panel members in Heart Health India Foundation. We are really extremely happy to have you on the panel, sir. So about Heart Health India Foundation, just for the viewers, um, it is basically an India's first patient-led organization working on cardiovascular diseases, and it was started back in 2020 by the founder Ram Khandelwal. He himself is a young heart attack survivor, and it was started along with his wife, that is Aditi Khandelwal, and it started as as a very small Facebook group, and now it has been established as a foundation, and with about 300 volunteers working continuously in this foundation. So what does Heart Health India Foundation do? We basically spread awareness. We have our support groups, where we support patients who have doubts, things like that. Moreover, we do advocacy. We give policy inputs for patients, for people who want to lead a healthier lifestyle, who want to maintain a healthy. So we have other services also, that is support groups, counseling services. We also had awareness campaigns. We had Run for Heart Health back in Mumbai. We have health screenings, CPR trainings, and so on. So this is our team, that is Ram Khandelwal, Aditi Khandelwal, and we also have Dr. Virendra Sarwal on our panel along with you, sir. So that is all about Heart Health India Foundation. And I would also like to give a small introduction about you. That I just, I was looking through your profile, and I mean, it's a pleasure to, have you on board. And um, just for the viewers, I'll just introduce you. So Dr. Christopher is a renowned consultant cardiologist from Mushirabad, Hyderabad, with 16 years of experience, and he's widely recognized as the best cardiologist in the area. Dr. Christopher holds an MBBS and MD in internal medicine from Christian Medical College, Ludhiana, and a DNB in cardiology from Care Institute of Medical Sciences, Hyderabad. And he has further specialized with fellowships in cardiac imaging from Harvard Medical School and George Washington University, USA. And Dr. Christopher, he currently serves as a consultant cardiologist at Care Hospitals, Hyderabad, and Dr. Christopher is also an executive member of the Asian Society of Cardiac Imaging and has numerous national and international publications to his name. Dr. Christopher's expertise spans cardiac imaging, echo, and so on, and specializes in heart failure management. And we are really honored to have you, sir, today. Welcome, Dr. Christopher, and thank you for joining us.
Yeah, thank you once again. And I think with the epidemic of heart disease that is afflicting the subcontinent, especially India, I think foundations like yours are the way to go because as cardiologists, we are just at the tip of the iceberg in terms of our capacity to serve people or rather change the course of this epidemic, which is about a million times larger than what COVID was. And it's afflicting the real drivers of the GDP, the young people, 20 to 40 years, crippling them, killing them, and really slowing down the economy of this nation. So it has to be a very wide grassroots type of approach, broad-based approach, simple approach to get people to do what is called primordial prevention. We will never have enough cath labs, operation suites to take care of the heart disease that is currently exploding across the country. So we have to do something that will cause what is called primordial prevention, which means not controlling blood pressure and sugar, but actually decreasing the overall salt intake of the community and the sugar intake of the community to actually prevent hypertension and diabetes, which are the biggest drivers of ischemic heart disease. So we need to go really down to the root and make those changes there rather than at the fruit or vegetable level. We will never have enough scissors to do that. So thank you once again, and I think you guys are doing a great job. And if I can make a small but noticeable change, well, then I think my job is well done. Thank you.
Thank you, sir. Okay, so let's begin today's discussion. And the topic is all you need to know about CT angiography. So my first question is, in simple terms, what is CT angiography and how is it actually different from the traditional angiography?
Yes, so as I said, when we're talking about prevention, and we do know that heart disease is a epidemic, we know that 1 in every 4 Indian above the age of 18 is hypertensive, has a high blood pressure. 1 in every 5 Indian is diabetic, and these two are the biggest drivers of heart disease. India currently has possibly, arguably, one of the largest number of patients with ischemic heart disease. That's the thing we are talking about today. There are other forms of heart disease which we don't want to talk about. And more importantly, it has the highest mortality rate in the world today. So number is more, mortality is more. Now, during this quest and when I was training, I've never actually heard of a CT scan being used. The only tools that I had when I was training way back in the 90s and early 2000s was an ECG, an echocardiogram, and every patient would be taken to the cath lab. Now, the cath lab is a very expensive place. It's a very sterile place, costs a lot of money. It's invasive. You've got to puncture the radial artery, so it requires skill, precision. Complication rate is always inbuilt because it's a precision thing. And because of the expertise involved and the logistics, it cannot be run as a 24/7 system. And obviously, because of the expertise and the danger involved, it can be done only by a select few people. So if I were a physician, and I was a physician at one time after my MD, if I suspected a patient of having heart disease, the general suspect is always clinical, not biochemical or imaging. And when I say clinical, it means that anybody in a particular age group, let us define them as above 18 because we're having very young patients with heart disease, who has a chest pain which is central in location, squeezing in nature, which is initiated during activity and comes down or decreases when you stop the activity, or completely gets relieved when you put a tablet of sorbitrate under the tongue. That's what you call as a clinical classical angina. So in that particular patient, when I have that symptom, or You could have an equivalent shortness of breath fitting the same description, or you could have some feeling of anxiety or acidity, again having the same. Anywhere from the jaw down to the epigastrum, when I say epigastrum, it means the upper portion of the abdomen, is fair game for the exhibition of heart disease. That means I could have jaw pain starting when I walk, the jaw pain stops when I stop, and the jaw pain gets relieved with sorbitol is equivalent to a central chest pain. And fortunately or unfortunately, diabetics, which we have a large number of them, have a large number of atypical symptoms, which we Indians like to sort of pinpoint as acidity or gas. And when we have a lot of spicy food, and we do have that, it's very easy to confuse this with a worsening of acidity, which generally is a very benign condition. So we also have a lot of people in the current cell phone era and laptop era who have a lot of cervical spondylitis or cervical spondylosis because of constant bending and looking at their laptops and phones. And the pain which comes because of that is exactly in the same area that we talked about. So acidity, heartburn, cervical symptoms, and coronary pain are almost virtually identical, and the geographic area from the jaw to the upper abdomen is virtually the same. So if I'm a physician and I have a clinically suspect patient, a 32-year-old executive diabetic hypertensive with the father who had a coronary bypass at the age of 55, I am looking at a very strong layer of risk factors pinpointing to heart disease. Now, earlier in the day when I was training, we would refer that to the cardiologist. He would do an ECG, but generally would be normal. He would do an echo, generally would be normal. And he had to take the case to the cath lab. It's invasive. You need to be shaved, you need to be prepped, you need to be fasting, you need to come there first thing in the morning. And then after cleaning, draping in a very sterile environment, then I would puncture the radial artery. We were actually puncturing the femoral artery, which is the leg artery initially. And then now we have moved to the radial, which is more convenient. And I would insert a long tube or catheter into the radial artery, then the axillary artery, the subclavian artery, and then down the aorta, and then position that catheter into the mouth of the coronary, left and right, inject with some contrast, take some pictures, and then I would develop that film, and I would give you the diagnosis and tell you whether you had an obstructive or a non-obstructive disease. Now, when we were doing this, obviously we realized even if we worked from morning 8 to 8, and even worked on the weekends, which many of you who are not in the medical profession enjoy your hobbies and your various other things on the weekend and get your houses straightened out. We would be working in a radiation filled area. And when I talk about radiation, the radiation exposure that we would have from morning to night would be equal to maybe someone who has had a little pinpoint exposure at the Hiroshima blast site or the Chernobyl blast site, which is a lot of radiation that we would get. And we would be doing this and still not making any dent in the way we look at heart disease, simply because 40% of these patients with these classical symptoms who we took to the cath lab actually had normal angiograms. So that means 40% of the patients could have been saved this procedure. It's a lot of cleaning, draping, sterility. I'm in the hospital for at least half day, if not the full day. I can't move my wrist or carry anything or drive for at least a day, if not more. And if we did it from the femoral, if my radial wasn't good enough, then I couldn't even walk for half the day. I was lying down. I had to be taken home lying down. There's a lot of inconvenience, if not pain. And just try doing this to about 20% of our population of 1.5 billion, and then you're looking at possibly having as many cath labs as there are doors in the Great Wall of China. So I'm just kidding, but that's a kind of expense that our country just simply cannot afford. And neither the government nor the private sector would be able to invest in that kind of thing. And as I said before, that 40% were normal, because the angiogram essentially is a catheter which is put in the mouth of the coronary, and you give dye, which basically means you're looking at the lumen. Lumen is nothing but a hole. But we now know from various postmortems and a lot of ultrastructural techniques over the last 2 decades that actually the disease of coronary arteries doesn't start in the lumen or in the hollow, but actually starts in the wall. The wall is the greatest activity. The wall means the structure surrounding the tube. So if you're wondering about the if you're wondering about the tube or lumen being important, we have now realized that actually it is the wall which is the seat of the activity, especially in the earlier phase of heart disease, wherein you can really make a difference with lifestyle and medication, which is the norm for more than half of the people. When it does come into the lumen and my angiogram is actually abnormal, then the damage is already done. And medicines really don't act at that level, although you have to give it. You have to put in stents or go for bypass. And just giving you a ballpark figure, it's around 2 lakhs for a stent and about 3 lakhs for a surgery, give and take, depending on where you are and what kind of insurance you have, so on and so forth, which again, when you're looking at about 40% of 1.5 billion people with this disease, and more than 70% of them not being able to afford a square meal, or let's not say a square, 2 square meals. Just imagine the kind of cost that would put the economy through. Then you will understand the ramifications of this. So 2 decades ago, and this was when I was just visiting the US for my training in the early 2000s, they started experimenting with an existing technology called a computed tomography, or a machine which would take slices of the body by passing X-rays and then creating pictures out of it after sending it through a semiconductor chip. And this technology became very robust. This is a technology which possibly entered in the 1970s or early 80s. And it became the to-do technique for lung disease, abdominal disease, and brain, especially after traumatic road traffic accidents. It was a great tool for static body tissue, like you have in the abdomen, the chest, and the brain. It was a very well-established technique, and you had the slices, or what we call the technology moving from 4 to 6, 6 to 12, 12 to 16, and then it came to actually 64 slices, which meant you could cover a larger part of the body in one go. Now, this certainly was only good for static tissues, because we know that the heart is a mobile structure. It beats at around 60 to 80 beats per minute. And the coronaries, which you really want to see, move at a much faster rate than even the heart that is moving. So if you had to see a moving structure, the existing CTs could not really work. You could not capture. So a couple of technological advancements came in, and one was using an ECG gating technique and thereby only pick up the portions of the heart which are at standstill. That is what we call diastole, and the heart relaxes in the cardiac cycle, and only pick up those pictures. The second technology that moved in was the ability to decrease the heart rate using intravenous drugs like beta blockers. And the third technological revolution was the use of brush rings or slip rings, wherein the ability of the detectors on the CT scan to move very quickly without mechanically having to interlock with each other became a possibility because of an engineering solution called brush ring technology. And then the speed at which the gantry moved again became increased because of, again, an engineering sort of revolution, where instead of moving at about a second, these new scanners would take a complete revolution at 1/4 of a second. And thereby, the temporal resolution, which is defined as the ability to pick up an object which is moving, became very high, just like how the camera technology moved from the late 60s to 80s, and then you got the DSLR technology, and you could capture athletes, freeze frame, birds in motion, so on and so forth, based on the collimator or the shutter, and the same principle works here in the CT. So a lot of these engineering technological advancements after the Second World War ended up fusing together and finally creating the first CT scan which would actually image or try to image the coronaries. And then as we started imaging them, the technology grew and more advancements came in the field. And now we have a scanner which is sold, which has a 500 slice technology, which can image the heart, the entire heart, in 1/4 of a second. And because of that, the heart rate, which we try to decrease to make sure that the diastolic time or the time when the heart is still to image it, it becomes almost instantaneous. So even if a patient had a higher heart rate in the older technology, we could not image this. The patient's heart rate had to be brought to 60 using various techniques, intravenous injection, and then we could do it. But with today's modern scanners, you have something called a 500 slice technology, a dual source technology, where instead of one detector, we have two detectors. And the latest invention now, and I was part of that meeting recently in the Asian Society, is photon counting detector. So that means every little photon that comes in from the X-ray tube can be actually counted mathematically, and that energy can be projected into an image, and that leads to crystal clear images, 1/4 of the radiation being used, and in a fraction of time, and the quality of images is like what you would see possibly in the OLED televisions, for those of you who have them, lucky enough to have them, compared to just the HDR technology television screens. So there's been a lot of technology driving this, and the big players in this field are the Philips company, GE in the United States, Philips is Dutch, Siemens Germany, and Toshiba and Canon is Japanese. These are the big players. We also have a Chinese group called United Imaging, which is also in this highly contested battle. And what it does is that you're able to take a picture of the heart. Let us say the average machine, I'm not talking the really high-end ones, in about 4 to 5 seconds. And the patient is lying still in the machine. There's no catheter being introduced. There's no radial artery being punctured. Simple intravenous line that you get. You get a little B complex injection. And contrast goes through, it's iodinated contrast. And in 5 seconds, scan is over. Patient comes out, he removes the IV, puts on his clothes, and he's off to work in his week. So it's just led to an unbelievable advancement in scanning. And as I said, why doing scanning when we had blood tests and echoes and ECGs? We did find that most of our patients whom we did this were based on a small town, Framingham, not very far from where I worked in Boston, about, I would say, around 50 to 60 kilometers. It's a predominantly white town, Caucasian town. And it has about 3 to 4 generations of survivors who have been examined and evaluated, and their prognosis seen based on their blood pressures, their sugars, and the cholesterols. Now, it seems very amusing that a purely homogeneous town like this would be able to actually replicate what happens to other races like ours. And unfortunately, because we did not have a nice town, we did not have that kind of large amount of data and follow, we're forced to follow what the little town of Framingham told us. And we did find in our patients that it was not always true. So we did find that patients with very high lipids did not always have heart disease. Patients with normal lipids did not always have no heart disease, so on and so forth. So in the outer extremes of the data, we found a lot of anomalies. Yes, more the lipid you had, more the sugar you had, more the BP would be expected to have more disease, but there was no linear correlation. So we decided we need to actually look into the artery. And the other advantage of CT is because you're imaging from outside, you got to see the wall, which is where we feel. And now we know that that's where all the action is. In the catheter, because it is from inside, you don't see the wall. And from the CT, because it's from outside, you see the wall. So CT has some distinct advantages. It's non-invasive. There is radiation, but I said with the newer forms of machines, the radiation is very low. The best part is the operator doesn't get radiated. So that saves us to do many more patients for many more years comfortably. It's very fast, 5 seconds, can beat any radial angiogram or operator by a mile. And it's non-invasive. Normal CT in a normal hospital or diagnosis center can do it. The complication rate is very low, if at all. And it's very convenient and is a large data set which today's machines and today's software can really manage. And you're getting the whole heart picture, all the 3 coronaries, and you're getting to see what is there outside on the wall, and you're getting to see disease early, and you're able to take those measures that you would have done even if the angiogram was normal. So I have a patient, diabetic hypertensive with some pain, and the angiogram is normal. So generally in the past, as a cardiologist, I would have written a report saying, patient has pain, hypertensive, diabetic. Coronary angiogram is normal. Please treat as a case of non-cardiac chest pain. And I refer it back to the physician who sent me. And 6 months later, the patient comes with worsening pain and he comes to the emergency room and he drops dead. And when we look at him and the enzymes and the echo, we realize he's had a massive heart attack. This is a patient whom I pronounced the angiogram as normal because I had no idea what was going on in the wall. I had no idea what is going on in the microcirculation, which the angiogram cannot see, that is beyond the vessel and before the myocardium. And because of that, I said it is non-cardiac because I didn't see anything. And this patient was not on statin, not on aspirin, and his blood pressure and sugar were not that well maintained because he has no heart disease. So there was no real impetus to really get the sugars down and the BP down. And 6 months later, he comes with a massive heart attack and dies. So now we know that a normal angiogram does not mean that patient does not have ischemic heart disease because all the action in the wall for up to 30% of the lumen is almost invisible on a coronary angiogram. So the CT picks up very, very early disease, very, very early disease. And now we also know that not only the stenosis or the narrowing, but it is the morphology of the plaque that we're going to call it now is important. So if I'm a 30-year-old gentleman, diabetic and hypertensive, with a lot of calcified blockages of plaques, my chance of heart attack is half than you, similar age, similar diabetes, similar hypertension, but my plaques are more of lipid in origin. The person with a lipid origin has a 3 times more chance of having a heart attack than somebody with calcium. And the CT can very reliably differentiate between these different kinds of plaques. So not only now you're assessing the narrowing, not only you're able to see the myocardium, which is the end result of the result, but you're also able to see the morphology or the histopathology of the plaques, and you're in a position to give some idea that what is the chance of this person having a plaque rupture, because we know that is the inciting event for a myocardial infarction rather than just narrowing alone. And when we look at our patients who in the past couple of years, due to various reasons, including financial, had severe calcified blockages, three triple vessel, they keep coming to us, they're doing good, they have a little pain, but they never had heart attack. So we used to wonder why. Is God good to them? Yes, definitely, no doubt. But in addition, those plaques are all calcium. And because they're calcified and because they're important, they've developed very nice collaterals around them. They're doing pretty well. They have their daily sort of activity, which is not superlative, but they're able to get by, and they've never had a heart attack for the last 10 years. And you have a young person, 28-year-old or 30-year-old smoker, angiogram done normal, and has a sudden cardiac death in the gym. And when we look back, we see that he had a 20 to 30% lipid-rich plaque, which was sitting in the artery, unnoticed by the angiogram, and by lifting more weight than he was supposed to, doing little more cardio than he was supposed to, the plaque ruptures, exposes the vessel or lumen to a lot of lipid-rich material, which is very thrombogenic and causes the entire vessel to be cut off in seconds, and thereby leading to have a massive attack compared to my other patient who's 68 years old, has severe calcified vessels, has a little bit of angina, but the lipid plaques are almost tomb encased by calcium, which is a very hard substance, and therefore the chance of rupture is very, very low. So all this information we started getting when we started looking at the CT scans, and that's led to a huge revolution because it is so easy, so nice, it's available all across, and the CT scans are much cheaper than angiograms, angiographic suites, and obviously they're much more safer. There's no radiation to the operator. The operator sits outside, and you're getting all this important information. So it has led to a huge explosion of coronary artery disease dissection, and more importantly, you did not have to be a cardiologist to make this all out. If you look at the large physician population in our country, I would say cardiologists represent about 0.1% of the entire healthcare population, which includes the gynecologists, anesthetists, physicians, all sort of. Now, you can't expect 0.1% of the healthcare physicians to make a diagnosis concerning something which has epidemic proportions. Just not possible. So, what do you do? By doing the CT scan, an average physician can get a report about the plaques, the narrowing, and he can make a decision whether to actually send to the cardiologist if it's obstructive, more than 70%, or treat the disease himself, which is very easy to treat because you have to give a statin, you have to give an aspirin, and a beta blocker. And this is something that we have learned in medical school, and a physician would have learned it during his MD. So it's made the treatment and detection of coronary artery disease very democratic, which is something which I'm interested in because you have to have a technique which is easy, which is democratic, which large people can tap in to screen large number of people. So I believe it's a great technique. I happened to touch upon it by chance when I went to the United States. I actually went for training for cardiac MR and nuclear, but then I saw this new technology and I said, this is unbelievable, the way we're detecting coronary artery disease with these scanners. And when we're doing it in the emergency room, you could safely discharge these patients out of the ER very quickly, very reliably, without having them to be admitted, get costly treatment, occupy important beds, and get an angiogram the next day morning. So this is in short my journey with coronary CT. And then when I brought it to India, I was one of the first few people, and we set up a dual source scanner at Hyderabad at our flagship hospital, Banjara Hills. And till date, over the last maybe many years, I think we've done about somewhere in the region of around 30,000 scans.
That's quite a number. Sir, I asked you That was actually, in fact, my first question, and you comprehensively covered all about CT scan. In fact, without even asking, I think you're a doctor who definitely has gets a lot of patience and clearly knows what people really want to hear. And you gave us a really good history about CT scan and CT angiography and uh, all of it, how it evolved and the mechanisms that is involved. There is one question that I really want to ask. So you are comparing the cost. So how much does it actually cost to take a CT angiography?
Costs would depend on where you are. Are you in Delhi in a swanky five-star hospital versus a small little town in Bihar, maybe? So that's where the cost would differ. But generally, ballpark figures would be somewhere between around 8,000 to 12,000. And of course, if you're in some swanky place in Mumbai, it would even be 20,000, depending on the scanner they used and where it's used. But I would say cost to cost, the technology would not be more than around 6 to 8,000.
Okay.
Because the only reusable thing that is the ECG leads, which are fairly cheap, and IV line, again, very cheap, and contrast, hydrogenated contrast, which is fairly cheap. A bottle of contrast that we use is about 3,000 or max 4,000 bucks. So the other cost is based on the electricity that we would use, the personnel use, things like that. So if you want to adopt it as a screening technique and maybe the government or a large, a well-funded private group wants to do it, I could say that they could even screen patients at rupees 4,000 easily.
Sir, when you compare it to traditional angiography, how much does angiography cost?
Again, that would depend on where you are. I know there are angiograms which cost about 2 lakh rupees if someone famous was doing it for you in South Mumbai. But again, angiogram would be somewhere ballpark figure of around 8,000 to 10,000 rupees.
Okay. So at the same cost, we are getting a better technology over here, right? So who all can do a CT angiography? Is it just who has a heart disease or who have symptoms, or can anybody just go and do a CT angiography?
Yeah, basically, because there is radiation, although low, we want to use this technique only for those who actually need it. So in cardiology, we have a general rule of thumb wherein somebody with an intermediate risk of heart disease would be eligible. Intermediate risk is anybody who has the risk of developing heart disease in the next 10 years of between 10 to 20%. Anybody with more than 20% would generally prefer to go to an angiogram because the chance of finding disease is much more and that needs to be fixed. Anybody with less than 10 or 7.5% risk generally could be managed easily by treadmills and echoes and things like that because the chance of you picking up important disease is going to be pretty low. So intermediate risk of heart disease between 10 to 20% are the ideal patients who would have a CT. Generally, we look for symptomatic patients, some kind of chest pain syndrome, atypical, non-cardiac, cardiac, etc. So those are the kind of patients we want because it is costly, definitely, and there is radiation and there is hydrogenated contrast. So you need to have normal kidneys, you need to not be pregnant, you need to be preferably above the age of 40 for a lady and maybe any age for a man. There is a very, very small risk, but it is there of breast cancer in a younger woman less than 40. So these are some of the caveats we have before we scan patients. Obviously, depending on the patient phenotype, we would flout all these regulations. Sometimes we do it for pregnant people, sometimes we do it for young ladies, sometimes we do it for young people. But that all depends on the clinical context. But a ballpark figure is someone with risk factors, diabetes, hypertension, hypothyroidism, somebody with some kind of a chest pain syndrome, cannot be totally asymptomatic, who does not have a classical angina, and that's the kind of patient we want to scan because the yield of information is going to be maximum. We definitely don't want to take an 18-year-old boy who has chest pain because he possibly, had a hit with a basketball. That's not the kind of patient we want. Or somebody who is around 80 years of age, who's diabetic, hypertensive, has a couple of stents, bypass, and has chest pain. That's not a patient you want. So both the extremes we don't want. So the intermediate risk patient is a patient who's best suited to go for the CT scan.
Okay, sir. Understood. So is this procedure painful?
No, it's just the IV line that you would put. Yeah, almost any one of us would have had an IV line put in the emergency room for something or the other. So it's just the pain of the IV line. It's about a few seconds pain. That's it. There's no catheter going in like angiogram.
Okay, understood. So I understand there is some kind of a substantial amount of radiation that this emits. But apart from that, the dyes that you use or the pre-procedure medicine, does those have any kind of risks?
Not really. The contrast that we use today, ideally contrast, are very safe, very well tolerated. 20 years ago, or maybe 15 years ago, 20 years ago, we had high density contrast materials, very ionic contrast materials. So they had a lot of reactions. Patients had to come extremely fasting, couldn't even give them a drop of water. They would have a lot of nausea and vomiting after the contrast. So that was a big limiting factor. But today's contrast material, which is worldwide available, is smooth, easy. In fact, I make sure my patients have a lot of liquids before they come. They enjoy the tea, coffee, and they come. No fasting required. They can have a biscuit or two, light stomach, and they just tolerate the procedure very well. It's a 5-second procedure, and after 5 seconds, they're done. So just very easy in, out, and very, very simple.
Okay, perfect. So that was quite a comprehensive interview that we had. We discussed a lot of things. In fact, without even asking you, explained everything really well. I really believe this would be very beneficial to everyone who hears this, not just people worried about heart health or just anything like that. Not just patients. Anyone who hears this, it's a lot of information. It's a lot of knowledge, valuable knowledge that you have just shared. So, at last, do you have anything to tell our viewers from your side regarding this?
Yeah, I think we are a population in the subcontinent which is extremely at high risk for heart disease. So, and as I said before, we're getting heart disease early. We are getting afflicted by heart disease early. We are getting it about 10 to 15 years earlier than our Western counterparts. The disease is much more extensive. The disease is much more malignant. Women are also getting affected. Young people post-training, just getting into the workforce, are getting affected. So I believe we have to look at it very seriously, carefully, visit our healthcare physician, and make sure that we are screened. I feel that we should be screened at the age of 18 when we go in for university after our NEET and whatnot, IITs, because that's where the disease starts. We need to adopt primordial prevention, not secondary prevention after the attack is over. I have a couple of IIT students who had heart attacks and came to me, I did their stenting. I feel really bad for them. We need to go out and exercise. We need to decrease our calorie content, our junk food. We need to adopt healthier lifestyles, get a little bit of sunlight, use the weekends to move around, move about. We need to become conscious about our sleep time. It's very important. We need to cut down the salt on the table, the processed food on the table, the ketchups, the chips. We need to be careful about the sugars that we consume in our drinks, in our beverages. We need to adopt a ground upward approach as a country, as a nation. Otherwise, our economy will take such a battering in the next 20 to 30 years. I believe by 2040, if we have not made these corrections today, we'll be a nation which will be crippled. Our workforce will be crippled. The number of man hours we're going to spend in the hospitals are going to be more. And we simply don't have the time or the money to build more hospitals than we have today. So it's a clarion call for the young people who are 18 years to about 30, who are just entering the workforce, that we need to introspect seriously, because we have something worse than COVID, worse than cancer, which is engulfing us slowly, and it's going to be a big drain on the nation's resources. Thank you.
Thank you so much, sir. Thank you for spending almost an hour with us, explaining everything really well, very patiently. I understand as you mentioned in the beginning, you're someone who works from 8 to 8. When we enjoy our weekends, you still keep working, and that's something I have a huge respect for. Healthcare professionals like you, who spend a lot of time, are patiently working, helping people, clearing people's concerns, doubts, making them comfortable when they come to you with help. Thank you, sir, for spending your time with us. I really hope you also had a good time spending with us. Thank you, sir.
Yeah, thank you very much. And I pray and hope that the message gets circulated as much as possible, because our wish is that India enters the rank of the industrialized nations, at least by maybe 2040. We move from our third world ranking to first ranking, and anything that we do, all of us together and individually, I think should be targeted at this. I think we have a great place in history for our nation. We have been under the cover for too long, and I think it's time that we, get energized, move up, and start working together and building up a first world country. Thank you, and Jai Hind.
Thank you, sir. Sir, also to mention, Ram sir really wanted to join this call. Really wanted to get to talk to you, but he had a meeting from 7:30 onwards for the Global Heart Hub. So that's why he couldn't join. He mentioned that I should definitely convey his regards to you.
Sure. Thank you. Thank you very much. And thank you once again. Good night.
Good night, sir. Thank you.